Welcome. This is part 2 of heart failure and more. In this presentation, we will discuss therapies for management of congestive heart failure. We will also talk about drug therapy as well as complications of heart failure, most importantly, pulmonary edema. We will also discuss the pathophysiology that differentiates right versus left-sided heart failure and the assessment findings for both right and left-sided heart failure. Previously, we discussed that lifestyle changes can have a dramatic impact both on the management of heart failure symptoms and on the pace or rate at which the condition progresses. We talked about the importance of smokers needing to quit smoking because smoking has adverse effects on the heart and blood vessels. We talked about the importance of exercise done in moderation, that it can help the heart pump more efficiently and reduce the demands of the heart. And we mentioned diet, of course. Diet is a critical part of this process. The two most harmful ingredients in a patient's diet are salt and alcohol. Remember that eating salt forces the body to hold on to water. And that water, unfortunately, in this patient collects in the lungs. And other third spacing occurs as well. We have swelling in the legs and abdomen and edema in those areas. And all of that holding on to water makes it difficult for them to breathe. By eliminating the salt, of course, that'll help them get rid of that extra fluid. Alcohol as well is harmful for patients with congestive heart failure. Alcohol makes the heart more sluggish, so to speak. But it's good to know that the heart function may improve if the patient stops all alcohol intake. And remember this important thing before we get into the drugs for treating CHF. It is not a good idea to drink large amounts of water when you have heart failure. The therapy for heart failure is directed toward eliminating extra water from the body. And so that is the focus there. All right, so moving on. Once all the lifestyle changes have been tried and the patient has not reached a satisfactory goal, then we might have to be putting them on medication therapy. Okay, and so we're going to go over all of these medications that are used in the treatment of our patients with heart failure. And you've heard of these medicines before. So let's review. The first category of drugs that we'll be talking about are the ACE inhibitors. The ACE inhibitors lower blood pressure, in effect decreasing afterload, which allows the heart to work more efficiently. Okay. Then we have the angiotensin receptor blockers, often referred to as ARBs. These drugs are similar to ACE inhibitors, but they do not cause a cough, okay, which can be annoying to some patients. However, the ARBs are a good alternative if ACE inhibitors are not well tolerated. And the beta blockers. Beta blockers are frequently used in heart failure because they control high blood pressure or because they control the fast heart rates. They also help the heart pump more effectively. Again, care must be taken to start these drugs at a low dosage and then gradually increase the dose. under the supervision of your physician, of course. Now, individuals may actually feel a little worse during the first few weeks after starting beta blockers. However, symptoms generally improve and therapy can prolong life. And there are studies that indicate beta blockers can prolong life, improve heart function, and decrease hospitalizations. Next on our list are the diuretics. These drugs help eliminate extra water and salt that causes swelling of the ankles and shortness of breath. Some diuretics may cause excess loss of potassium, such as furosemide, which is your Lasix, torsemide as well. Other diuretics, such as spironolactone, may cause your body to retain potassium. So aldactone or spironolactone may be helpful in avoiding serious complications of heart failure. And remember, the diuretics really are effective because they decrease preload, that extra volume, so that allows the heart to pump and work more efficiently. And then there's digoxin. This agent helps improve symptoms of heart failure and helps avoid rapid heart rhythms. It also is a positive inotropic agent, which means that it will cause the heart to contract with more strength, so it improves contractility. And finally, a drug that you may see being used in the treatment of heart failure is a potassium supplement, like K-Dur, for example. This is sometimes required to replace the potassium that is lost from the body during diuretic therapy. So monitoring potassium level is important in the treatment of heart failure. But remember that our prime focus in heart failure is to make sure that the heart is beating efficiently so that it can move blood forward out of the ventricles, especially the left ventricle, into the aorta, and to perfuse the rest of the body. We do not want blood to back up, because that'll force fluid into the tissues of the lungs, both lungs. So that is the whole thing. We don't want fluid accumulating in the lungs, because then we have impaired oxygenation and the inability to breathe. This slide is helpful in remembering how we treat heart failure patients. The acronym that we could use, or the mnemonic, is UNLOAD FAST, with each of those letters representing a therapy that should be initiated with heart failure patients. Okay, and one of them is an upright position. We've discussed that in the past, what the problems are when the patient lays down flat, especially at night. Then they have that waking up in the middle of the night because they feel like they are drowning and they're gasping for air. By sitting upright, we do a couple of things, including having the fluid only at the bases of the lungs, and also decreasing preload, because when you're upright, more of your circulating blood volume is out in the periphery and less is returning to the right side of the heart. So that is always very beneficial. Nitrates, we discussed how nitrates work with the vasodilation effect. You can review that. And Lasix is the diuretic most commonly used. Oxygen. Okay, so the number one nursing diagnosis, of course, is going to be decreased cardiac output. But when that occurs, the tissues are not being perfused well. We have ineffective tissue perfusion, so we definitely want to initiate supplemental oxygen therapy. These people are having perfusion problems. Once again, anytime there's a perfusion problem, it's very appropriate to administer oxygen. Okay. And then we just went over the ACE inhibitors and their important role, especially in decreasing afterload, and digoxin for increasing contractility. And then we have FAST. We want to, F for fluids, decrease their fluids, okay, intake. And part of that is done by the S there by restricting their sodium intake. We want to decrease afterload. That means that the heart has to not work so hard to overcome the resistance to get the blood out of the ventricle. Okay. And then we have to do diagnostic tests. We have to monitor our patient who's under this therapy. We especially will talk about DIG. If they're on DIG, then we need to do DIG levels, because DIG can be toxic if it is not in the therapeutic range. And we do ABGs, or arterial blood gases, so that we can get a really good picture of our patient's acid-base status and their oxygenation. And we monitor potassium levels. The reason we monitor potassium levels, once again, is because of the diuretics, especially if they're taking a diuretic that is depletes our potassium. And the risk with potassium, remember, is not related to heart failure. The risk with potassium is related to electrical conduction problems. Okay, so heart failure is not about electrical conduction problems. Heart failure is about the structure of the heart itself and its inability to pump. Let's mention some of the complications that can occur when a patient has heart failure. The first of these complications is a pleural effusion, as you see in the picture here. That means that there is an accumulation of fluid in the pleural space between the parietal and visceral pleura. Now remember, that fluid that's backing up into the lungs, sometimes it's forced into the interstitium or lung parenchyma and alveoli, but a patient can also develop fluid being pushed into that intrapleural space. Now, another complication of heart failure is arrhythmias. And that is because as the heart enlarges, and especially as the left ventricle stretches, there is a stretching of the cardiac fiber cells, the fibers and the cells. And that actually can distort the electrical conduction pathways of the heart and lead to cardiac abnormalities or arrhythmias. Now, another complication is the development of a clot in the left ventricle. When the left ventricle is overstretched and enlarged, blood is not moving efficiently through the chamber. And so the blood that is not ejected is left in the ventricle and can, due to stasis, result in the formation of a thrombus. That, of course, is very dangerous because it's usually quite a large clot, and that clot can become dislodged, and that would be life-threatening. And then another complication of heart failure would be hepatomegaly, or an enlarged liver. And we'll see that especially in terms of our right-sided heart failure patients, as fluid backs up into their abdominal space and abdominal organs. But the one complication that we will spend a lot of time on is the complication of pulmonary edema. In our patients, actually this can occur in both chronic and acute heart failures. Okay, just to clarify that. Pulmonary edema can result from or follow chronic or an acute event. Either one, any type of heart failure can lead to pulmonary edema. It has a hallmark sign, and so I want you to highlight this. what happens when the fluid backs up into the lung tissues and into the alveoli, it also disrupts those little tiny capillaries that are surrounding the alveoli. So there is damage to them, and so there's a little bit of blood mixed in there with the fluids. So that the hallmark sign is pink frothy sputum. When the patient gets fluid and tinged with blood in their lungs, they start coughing, and what they produce is pink and frothy because it's made of protein in the tissue fluid has protein in it, so that makes it frothy. And this is what they cough up. It's very characteristic of pulmonary edema. So it's referred to as the hallmark sign. So if you highlight pink frothy sputum, when you see those words in the stem of a nursing question, you should think automatically pulmonary edema, okay? Because it is the hallmark sign. So that is pulmonary edema. And it's, as I said earlier, it's the rupture of the alveoli letting blood into the airways, okay? And those little capillaries actually that are surrounding the alveoli that leads to the blood into the airways, and then they cough it up. And truthfully, they are drowning in their own secretions, okay? And they present that way as if they can't breathe. So, pulmonary edema is an abnormal accumulation of fluid in the interstitial tissue and alveoli of the lungs. It's caused by both cardiac and non-cardiac disorders, but right now we're talking about the cardiac disorder. Cardiogenic pulmonary edema is a sign of severe cardiac decompensation. And that's what we're talking about with heart failure. The heart itself is decompensating. It cannot pump the blood forward. So as contractility of the left ventricle decreases, those pressures in the lungs, the pulmonary hydrostatic pressure, increase, which forces fluid into the interstitial tissues. Eventually, this increase in pressure causes fluid to enter the alveoli. So ventilation and gas exchange are severely disrupted. Shortness of breath with activity is the most common symptom of heart failure. So the result is fluid leaking into the lungs, a condition called pulmonary edema. Fluid retention in the body by the kidneys can also be a culprit in developing pulmonary edema. This situation translates into shortness of breath. So on this slide, I show you both a normal lung without fluid in the lungs and pulmonary edema. Okay. Remember, this is a cardiac problem because we're talking about cardiogenic pulmonary edema, and it is a true medical emergency. Remember, they can't breathe, okay? So that's a true medical emergency. Of course, they should go immediately to the emergency room because the patient is indeed drowning in their own fluids. Immediate treatment is necessary. The first thing that we need to do when the patient is in the emergency room is to promote rapid diuresis if they're in an acute pulmonary edema such as we see in this picture. And so the nurse is going to implement the orders. The physician is going to order Lasix, 40 milligrams IV push, and just a one-time dose, stat dose of Lasix, 40 milligrams IV push. Okay. Of course, we are going to work on getting the heart beating more efficiently, but at this point right now, when the patient can't breathe, we simply have to work on getting rid of that fluid in the lungs And of course, getting rid of fluid in general with the Lasix, the diuresis that's going on, is going to decrease preload as well. And then the heart can beat more efficiently. So it's a wonderful drug to be used immediately when a patient is in acute pulmonary edema to help resolve the situation. We can also help the patient by facilitating breathing when the patient is in acute pulmonary edema, and the nurse should place the client in a high Fowler's position. Okay? Now think about that. When you're in a high Fowler's position, whether they're on a stretcher, perhaps in the emergency room, and their legs are straight out in front of them, or they are dangling at the side of down the side of the stretcher, either way, less blood is returning to the right side of the heart when the patient is positioned in a high Fowler's. Okay? Less blood is returning to the right side of the heart because of gravity. Okay? So that's good because that decreases preload. And again, that helps to improve the efficiency of the heart, and it makes it less demands on the heart that is trying to work properly. Okay? So what are the signs and symptoms of a person in pulmonary edema? Well, they're short of breath. They're dyspneic on exertion. Okay? They have orthopnea. In other words, they're assuming that position that helps them breathe. They may be cool and clammy and diaphoretic. That's indication that we're having a problem with perfusion. We're not getting oxygen to the tissues. You become cool, clammy, and diaphoretic. They may demonstrate cyanosis, but that again is a late sign of poor oxygenation. And the characteristic symptom would be, as we mentioned earlier, that coughing up the sputum. And so it's a productive cough with pink frothy sputum. As a nurse, you're going to auscultate the lungs and you will hear crackles because of the fluid in the alveoli. They may be having problem perfusing the cerebral, the brain, and so they can start to have changes in level of consciousness, including restlessness and maybe even confusion. So these are all of the symptoms that they may present with. Okay, and they do cough and they do gasp for air. This medical emergency requires astute assessment and rapid intervention. The most important first action the nurse should initiate on a patient who arrives to the hospital in pulmonary edema is to administer oxygen and attach a pulse oximeter. Okay? So again, the first action that the nurse should initiate, because this person is having a problem with gas exchange, is to administer oxygen. Medications commonly administered include morphine, loop diuretics, such as Lasix, vasodilators, such as Nipride, which is another word for nitroprusside, which is shown on the slide. Other vasodilators, including dopamine or dobutamine, to improve myocardial contractility. And also, it's not uncommon for the patient in pulmonary edema to be given a bronchodilator, such as aminophylline, and that's to reduce bronchospasm. This is simply to promote breathing, doing everything we can to make sure that they can, we can improve their oxygenation and breathing. So we definitely don't want a bronchospasm complicating things. All right. And then we see in this slide the an X-ray instead of just a diagram or picture like we've been seeing. So know that in X-rays, these radiological images, black is air, okay, so that's good in the lungs. And all of that you see that's whited out toward the bases of the lungs and even approaching the mid-lungs is fluid, okay? So this patient is upright, but we see that the fluid is accumulated at the bases. So most definitely at this point you're going to hear crackles in the bases, but you're also probably going to hear them in other lobes of the lung as well, higher up. Of course, the worse the patient is, the more fluid in his lungs, then you may hear crackles throughout all lung fields. But as we treat the patient, for example, with the Lasix and other drugs, as the patient is in the hospital, we should find in our assessments that we don't hear crackles throughout the entire lungs as we're treating them, and as they're improving, we should see or hear, crackles only in the bases. And then, of course, before discharge, we wouldn't want to hear any crackles whatsoever. We would want to hear that the lungs are clear to auscultation, which is frequently abbreviated as CTA, clear to auscultation, before they're discharged. Now we're going to talk about what distinguishes right and left-sided heart failure. We're going to begin with the assessment findings of a patient who has right-sided heart failure. They do end up with right ventricular heaves, meaning the chest wall rises due to the enlarged right side of the heart. We can also hear murmurs. We see peripheral edema. We see fluid retention with weight gain. We see increased heart rates and edema in other dependent areas of the body. And we see, as in the diagram shows us, the accumulation in the abdominal cavity, which is referred to as ascites. We also see the enlargement of the abdominal organs because of the fluid that accumulates there. We see a hepatomegaly, enlarged liver, and truthfully, we can even see anasarca, which is a generalized body edema. And also we see JVD due to the backup of pressures and fluids, even to the upper body. Okay, so if you look at that list of findings in right-sided heart failure, you'll see that much of it has to do with fluid retention. And that is a big distinguishing factor. You notice here, you didn't see anything about breathing problems with right-sided heart failure as a result of right-sided heart failure. You'll notice on this list, it's mostly about fluids, okay? The accumulation of fluids and edema and ascites, the things like that. But you don't see anything related to breathing, okay? So that's very different than right-sided heart failure. Than left-sided heart failure, excuse me. So let's talk about what causes right-sided heart failure. It's caused by factors that restrict blood flow to the lungs. Another name for right-sided heart failure is cor pulmonale. Okay, it's the same thing. They use the terms interchangeably. It is an enlargement of the right ventricle, and that is due to high blood pressure in the lungs. And so what causes a patient to have high pressures in the lungs? Well, it is chronic lung diseases. So any patient who has had long-standing pulmonary disease is at risk of developing right-sided heart failure. Okay? Now, you've studied lung diseases, chronic lung disease or long-standing lung disease, and you've probably studied several pulmonary disorders. So any of those can lead to this high pressures in the lungs. Remember, the lungs are supposed to be a low pressure system. There shouldn't be any problem with blood circulating through our lungs. But when people have lung disease, and for a long period of time, the pressures rise in the lungs. That means it's very hard for the right ventricle to advance the blood when it contracts forward to the lungs. It meets a resistance. Okay? So it backs up. It backs up into the right ventricle, and that causes the ventricle to enlarge or perhaps become hypertrophic. Either condition can occur. But it all contributes to the failure of the right ventricle. Okay, so let's go and look over on the right side of this slide. We see signs and symptoms. These are what we've already mentioned, but it doesn't hurt to repeat them. We see congestion of the abdominal organs. Remember, congestion is the buildup of pressure and fluid in those organs. And we have the development of edema. So look here, especially dependent edema, for example, in our ankles and feet. So this patient might have a difficulty reaching over and trying to put his socks on every morning because of the swelling. Toward the upper body, we also have edema, and that is shown, excess fluid is shown with the jugular venous distension, or JVD, can be seen in these patients. And here's a picture that does show us JVD. You may recall that in a normal subject, the head of the jugular venous pulse is commonly seen at the level of the clavicle when they are reclined at an angle of 45 degrees. To put it another way, a JVP more than 5 centimeters above the sternal angle is elevated. And so this is what we can see, a markedly distended JVD when the central venous pressures are elevated. I love this slide because it explains the pathophysiology of right-sided heart failure, and in particular the hemodynamic effects of right-sided heart failure. Unfortunately, you can't see my cursor, so I'm going to do the best I can to explain this diagram in this video. You see the right side of the heart, and what is the right ventricle normally would like to eject the blue blood, it's shown here in blue, out through the pulmonary arteries, okay? And then the pulmonary artery bifurcates or branches to the right and left lungs. In this picture, we'll just follow, and normally that's the flow of blood in the body. But remember that these people have had long-standing pulmonary disease. So there is high pressure within the pulmonary circulation, and the right ventricle has a hard time making the blood go to the lungs in that direction. It meets a resistance that makes it very difficult. And so then the blood backs up. So follow the diagram, the blue line. From the right ventricle, it backs up into the right atrium, and then, as we see in this picture, the inferior vena cava. Well, it also backs up into the superior vena cava as well, and that's why we can see JVD. But this diagram shows us it backing up into the inferior vena cava. And if you follow the path downward to the abdomen and to the systemic circulation to the lower extremities, etc., you'll see that that added pressure of the backed up blood causes fluid to move into the tissues and into spaces where it should not be, including the abdominal space and ascites, as well as hepatomegaly there. And then we see edema, peripheral edema, as it backs up into the lower extremities as well with the systemic circulation. So that is what occurs when we have right-sided heart failure. I just will mention one thing, that frequently, as we said earlier, there is not a clear demarcation. That's not a patient who only has right-sided heart failure, because this is very much connected and related to each other, the heart, different sides of the heart. So it's not uncommon, even if they begin with one, that they eventually have both, in terms of both right and left-sided heart failure. Okay, but you will have nursing questions that ask you, what are the signs and symptoms of right-sided heart failure? And then you need to refer back to our list, and all of them mostly are related to the accumulation of fluid. But you see, the blood does not, if you follow the blue path in this picture, the blood does not back up into the lungs. The problem is they can't get the blood to the lungs. Okay, so here's a review slide regarding right-sided heart failure, also called cor pulmonale. And the patient does present with ascites, enlarged liver and spleen, weight gain, JVD, dependent edema. I mean, look at those ankles. You can even have cyanosis because of poor perfusion to the toes and the fingertips. And again, cor pulmonale is the result of a long-standing pulmonary disease. So it is secondary to chronic pulmonary problems, as stated in this picture, in this diagram. Okay. Now let's go on and talk about left-sided heart failure. The signs and symptoms: fatigue and activity intolerance. We talked a lot about the quality of life because of the decreased activity tolerance. And they may become dizzy. They may experience syncope. They may use pillows to sit upright, that pillow orthopnea, or use pillows at night. Okay, dyspnea, shortness of breath, cough, and crackles, perhaps rales and wheezes upon auscultation. They can also develop an S3 gallop. Now, let's follow the pathway of the blood in this picture when an individual has left-sided heart failure. Okay, so look at the left ventricle. Normally, when it contracts, it should force blood out through the aorta. You see the aortic arch in this picture, and there's no blood in it. There's no red in it. Okay, that's because the left ventricle is overstretched and weak and is encountering resistance, so that it cannot move the blood forward through the aorta, the aortic arch, and to the rest of the body. Instead, we see in this picture the red pathway. This is the way the blood backs up. From the left ventricle, it backs up into the left atrium, and the pressures and blood back up into the pulmonary veins, back into the lungs from whence it came. Okay, so when it's there in the lungs, we're having increased pressures, hydrostatic pressures, that are going to force fluid from the blood into the tissues. Okay, that's not the red blood cells, but the liquid portion of the blood is pushed into the interstitium and the alveoli. And again, you cannot breathe. The gas exchange is impaired. So that's why the left-sided heart failure patient presents with a very different signs and symptoms. Okay. So here are some signs and symptoms. Of course, we have left ventricular heaves. In other words, the left chest wall can rise up and down because of that enlarged left ventricle. We also have Cheney-Stokes respirations. And just to review for you, because I'm sure you've studied Cheney-Stokes in your unit on pulmonary unit. We have, with Cheney-Stokes, you have alternating periods of apnea with deepening rapid respirations. So that is a breathing pattern that can present with left-sided heart failure. We can also have, and I'll talk about pulsus alternans, I think toward the end of this presentation, but we have a difference in the strength of the pulses because of the increased thoracic pressures. Remember, with left-sided heart failure, we have a decrease in cardiac output and we have a decrease in blood pressure. Therefore, we have an increase in heart rate. We also have an increase in heart rate because the patient is hypoxic. Okay, so in order to get more oxygen to the tissues, the heart rate is going to increase. We also know the point of maximal impulse is displaced. We saw that it's displaced downward and to the left in a person with left-sided heart failure. And we have crackles. These adventitious or abnormal breath sounds, I should say, these breath sounds in the lungs. No, there would be adventitious breath sounds in the lungs. Okay. And they do sort of sound like when somebody eats Rice Krispies, that snap, crackle, pop that you hear. And with left-sided heart failure, we could, not necessarily, it's not all of these things that they have to have, but these are some of the things that we could find. They may develop S3 or and an S4 heart sound. So let's review a little bit about S3 heart sounds in heart failure. Remember, S3 occurs at the beginning of diastole or after S2. It's caused by the oscillation of blood back and forth between the walls of the ventricles, initiated by inrushing of blood from the atria. Okay. Now again, S3 is usually associated with heart failure. I like to think of it as sounding like sloshing in, because the inrushing of blood from the atria is what causes the extra heart sound. Now, that failing left ventricle may also be responsible for an extra fourth heart sound. S4 is a rare extra heart sound, and it occurs immediately before S1. This gallop is produced by the sound of blood being forced into a stiff or hypertrophic ventricle. Okay, remember that sometimes the ventricle becomes hypertrophic, especially in patients who have a long-standing hypertension, or if they have aortic stenosis, that is an aortic valve that does not want to open all the way. Those things can lead to that hypertrophy of that ventricle. So we do see it even in patients. Okay, well, I won't mention that. Sorry, I don't want to mention that. Let's just stick to our heart failure patients who can develop an S4 heart sound. So here's our review slide. We have left-sided heart failure. You'll notice the symptoms are quite distinctive, different, and most of them are related to the fact that the patient is having a hard time breathing. Okay. Again, we have perhaps and perfusing their body. So we have, because of the backup in the blood into the lungs, we have a cough, we have crackles in the bases, usually it starts, and then wheezing perhaps, and blood-tinged sputum, especially if it develops into a pulmonary edema. And because they're having such a hard time breathing, the heart, they're going to try to breathe faster. So we have tachypnea. The heart is also going to beat faster, and so we have tachycardia. All this in an effort to oxygenate the body. The patient has fatigue. They have dyspnea on exertion, orthopnea, confusion and restlessness if the brain is not being perfused well. And they can develop and have paroxysmal nocturnal dyspnea, waking up in the middle of the night, unable to breathe. And then we also have cyanosis, as demonstrated in this picture, as a late sign of poor perfusion, where the extremities are turning blue or purple and around the mouth and the fingertips. Now I have a question for you. NCLEX style question. This is a select all that apply. The nurse is awaiting the arrival of a client from the emergency department who is being admitted with a left ventricular myocardial infarction. In caring for this client, the nurse should be alert for which of the following signs and symptoms of left-sided heart failure. Okay, so I hope you decided C as in cat for dyspnea, D for crackles, E for tachycardia, and that's it. C, D, and E for our left-sided heart failure patient. Certainly JVD and hepatomegaly are associated with right-sided heart failure, and F doesn't apply to either one of them. Okay, very good. All right, I'm not going to be testing you on pulsus alternans because a lot of this is done through hemodynamic monitoring, and we're not getting into that. But I will expose you to it just briefly. This is the pulse. If you had a tracing of the strength of the pulse of a person who has heart failure, you may find that the strength varies with each heartbeat. Okay, so you look at the tracing below in a patient who has heart failure, and you'll see that the strength of the pulse it's strong and then it's softer, strong and then softer. Okay, so we see that softer beat because of the decreased cardiac output in our heart failure patients. All right, so I just want to introduce that concept to you. That is a possibility and another finding in our heart failure patients. Pulsus paradoxus is an exaggerated decline in blood pressure during inspiration. Okay, normally systolic pressure falls less than 10 millimeters of mercury during inspiration. In pulsus paradoxus, it falls more than 10 millimeters of mercury. When the systolic pressure falls more than 20 millimeters of mercury, the peripheral pulses may be barely palpable or may disappear during inspiration. Okay, so pulsus paradoxus may signal a complication of heart failure patients called cardiac tamponade, which is a life-threatening complication of a pericardial effusion, which we will talk about later in our perfusion content. But for right now, just know that it does exist, but we're not going to go into much detail about it at this point. So here we see some arterial pressure waveforms. We see the normal waveform. So if we have an arterial line in our patient, an A line, we will have an arterial waveform on the monitor, okay? Because of the transducer, it will convert that electrical pressure into electrical signals, and we'll see a waveform. So understand that the waveform can change, especially when a very diseased heart develops complications. Okay, so you can just see the difference here between a normal and a not normal waveform.